Hello, my name's Daniel. I'm Chief Exec of Epsom and St Helier Hospitals, which is one of the 4 acute trusts that serve 1.5 million people in South West London and Surrey. I'm here with my colleagues, Miles, who's the Chief Exec of St George's, Rachel, who's the Chief Exec of Kingston Hospital, and John, who's Chief Exec of Croydon Healthcare. Last time I stood in this building, wasn't competing with the cricket match, but I was with Dr. Claire Fuller, who is the chair of Surrey Downs Clinical Commissioning Group. And she introduced me by saying, since she's been a GP, there'd been 11 separate reviews of my hospital, and none of them had reached a solution that had benefited all her patients, and therefore hadn't been implemented. Well, we're confident that we can avoid the 12th review, because over the last few months, we have been working collectively together with the sponsorship of our CCGs to produce some clinically and financially sustainable solutions that will work not just for Claire's patients, but for all the patients of the 7 clinical commissioning groups that we provide district hospital services to. The problems we face are familiar to you all. We all struggle to deliver all the quality standards, and we're all in deficit. And if anyone knows the geography of South West London, it has a pretty complex and toxic political environment. Our vision is really quite simple. It's for our 4 trusts to work together to create a virtual organisation or chain. And with this, we want to do 3 things. Firstly, we want to ensure that the right patients use our hospitals appropriately. Secondly, we want to use our capacity and our workforce as flexibly and efficiently as possible. And lastly, we want to make some properly sustainable acute services for our population. So I'm now going to hand over to Miles, who's going to share with you for a few minutes some of our proposals and about how we are working together. And then I'm going to conclude with why we'd like to join this programme, and then leave Rachel and John to lead on the questions. Miles.
Thank you, Daniel. So, as Daniel said, we've got a pretty clear vision for what we want to achieve across South West London, but it's important that that's supported by equally clear ideas about what we're actually going to do and how we're going to approach this. In terms of the what, we've got 4 programmes of work, each with a distinctive approach, tackling the kinds of challenges that are actually familiar to people across the country, and play to the whole theme of replicability that is a watchword, if only any of us could pronounce it, for this session today. So, first of all, we are wanting to gear up our work on ambulatory alternatives for emergency care other than inpatient admission. We have established ambulatory emergency care in each of our organisations, and we will work together to, as I say, to scale that up, but build on the best practice that we have already identified elsewhere in the country and internationally. Second, we are all challenged by capacity and by length of stay. We have an alternative model of post-acute care that's been piloted in Daniel's Trust, which we want to roll out across South West London and make a real contribution to both the quality of care and the efficiency of care there. Thirdly, we have well-established clinical networks across South West London, but like many parts of the country, those networks haven't prevented us from being engaged in long and not always very productive debates about the configuration of services. We, through our Vanguard pilot, we want to challenge some of the orthodoxies about how services are connected to one another. We want to separate the assumption about how, or the debate rather, about how many front doors there are to our services, and to push as far as possible the networking of clinical specialties across our 4 organisations. Fourthly, we are going to collaborate on our back office services and maximise the efficiency that can arise from that. All of those are what's that many of you will be approaching all over the country, but in each case we believe we've got a distinctive approach. We also are clear how we're going to work together. Daniel said not only have we got an established network of organisations who've worked together for many years, but we've actually been working specifically on these proposals for over a year. We've got all of our boards signed up. in order to tackle the difficult issues, we have a memorandum of understanding, we have identified an independent chair and a full-time programme director. Importantly, we've got real experience of working together in this way. We already have two major contractual joint ventures across our organisations, one referencing the 5-year forward view to provide elective orthopaedics across South West London, another to provide a pathology service across South West London. So we know how we're going to work together and we are clear what we're going to do. And I'll hand back to Daniel.
So why would we like to be part of the programme? Well, Miles has already outlined that we're committed to delivering what we have said, even if we're not selected. But we're sure that being part of it will improve our chances of success, because the Vanguard should help us tackle the complex governance, clinical, political, behavioural, resource and evaluation issues or challenges that we know we're going to encounter in the next few years. But we also believe we've got a lot to offer the national programme. We think our approach of finding solutions that don't require years of structural change and instead identify pragmatic ways we can work together across a whole health system will be relevant and transferable across the NHS. We've already begun to share some of the tools we've developed with the CQC and other providers. The work we've been doing has brought us much, much closer together. And that's why we're supportive of our CCG's desire to enter the success regime, because we feel it would enable them to deliver collective leadership too. The reason for saying this now is because we've received some feedback that says the success regime and the Vanguard may not be compatible. But from my previous role, where I led the reconfiguration programme in North West London, I would advocate that joined-up providers and joined-up commissioners are the prerequisites for delivering successful change. To finish then, the Vanguard programme provides us with a unique opportunity to help us deliver what we've already started and for us to be able to assist other areas who are facing similar issues. But most importantly, we think this will enable us to deliver great care for all the people of South West London and the part of Surrey that we serve. Thank you very much.
Thank you very much. So some questions for South West London? Question at the back?
Hi, my name is Kashu, representing Royal College of Pediatrics and Child Health. Before I ask my specific question, a general comment, and that is about the lack of any discussion so far with regard to children's services. We're talking about acute care here, and more than a quarter of acute unplanned care is children. And this in the context of us in UK having the highest mortality, one of the highest mortality among children in Western Europe, and the fact that more than 25% of our emergency admissions are children. Specifically for you guys, the question is, you're talking a lot about reducing non-elective admissions, and we know that non-elective admissions, children are a large part of that, and there's been an increase of about 28% in the last few years in non-elective admissions for children. So what is your plan with regard to children's services?
So firstly, children are very much within the scope of our programme, and in relation to non-elective services, I think one of the things that Miles has talked about is wanting to strengthen the ambulatory emergency care models, and we've been looking at what's going on nationally and internationally to do that, and that very much applies to children. We've recently made some changes at a number of our organisations around paediatric assessment units, and we're wanting to take that work further.
Thank you. We've got a question from table 12, I think it is.
Good afternoon, my name is Trevor Clower, patients rep, and I'm from Nottingham. You say that, you're working together, with other providers as well as right across the board to strengthen your endeavours. Do you have any plans to include patients with that working together? And if so, can you give me an example how you're including patients and carers' voices?
So a good example is South West London Orthopaedic Centre. We have a strong patient engagement stream within that. So all the patients who come into the South West London Orthopaedic Centre are all involved in their care in terms of their care pathway, plus the patient group as well. So it's been a very successful programme which we're looking to take forward that and build on that within the work that we'll be doing in terms of ambulatory care. We think there are 500 people currently in our beds across South West London, the 5 hospitals, who should be cared for in other settings. So our task is to work with them, work with their families, work with social care, work with the voluntary sector, work with the other out-of-hospital providers. Some of us provide community services, some don't. It's up to us to work together, but particularly with the patients and their families, to have a better solution for these 500 people who are better off not being in our hospitals, but being in other care settings. If we can do that, then we will have a sustainable landscape for the people of South West London and Surrey Downs, which is much better for healthcare and social care than we have today.
Next question. Just here on table 6.
Hi, thank you. Just picking up the last point about coming together to provide services for a wider population. How's that going to fit with social care provision and the division across local government authorities?
So we know that we need to work across South West London, but also work with each of the local authorities. So, for example, in Croydon, we formed an Accountable Provider Alliance, which includes 5 providers, so us as Croydon Health Services, but also Croydon Social Care from the local authority, the GP Collaborative in Croydon, Age UK, and SLAM, the South London Maudsley Mental Health Trust. So we know that we need to work in Croydon with the local authority, but what we're looking for is best practice across South West London in terms of what we can do as acute providers that then can be modelled into the local circumstances, because the population of Croydon is different to the population of Richmond.
I think we probably can take one more question. So we'll take the one at the back. I'll come back to you, Glenn. On the back there, please. Thank you.
Kate Ansell, Patient Voice, Associate of Self-Help Nottingham. What I would like to ask is, if you're going to be discussing community care with the local authority who are having cuts to their budgets, will you, from within the Vanguard financial support, be able to help them to join with you?
So I think one of the key programs we've got, as John's alluded to, is around post-acute care. We're not talking about simply shifting responsibility for a bunch of patients to another entity, whether it be GPs or colleagues in social care. So we're talking about retaining responsibility for the patients that John's alluded to, but finding alternative care settings for those patients that enable us to provide the best possible care for them. Clearly, as part of that, we need to engage with our local authority colleagues, but we're not looking to pass responsibility for a whole load of care onto them.
I'm literally going to squeeze one last question in from Glenys here. Thank you.
The booklet says partners will focus on reducing non-elective admissions. How?
So one of the key things that we're going to do, so we're very much focused on the things that are within our control. And one of the key things that we know that we can do is to have a look at our ambulatory emergency care models. So as I alluded to earlier, we've been looking at best practice nationally and internationally. And we believe that somewhere between 20 and 30% of non-elective admissions can be dealt with through ambulatory emergency care pathways, which means that patients don't have to be admitted. So we can rapidly do diagnostics and get patients back to their homes.
Thank you very much. That's South West London.